Evening and good day, everyone. Welcome to My Ivy Offenses and our webinar tonight. It's great to be back with all of you, and I hope you had a wonderful day and are ready to learn a bit more, but also hear some useful tips, I'm sure, from Professor Sheryl Homa. You can see her right here. It's great to have you. This is your first webinar with My Ivy Offenses, so we are very, very happy that you were able to be here with us tonight and you agreed to present this particular and important topic. We will discuss male infertility, and this is definitely a topic that I think, in my honest opinion, I think it's still not discussed enough. So Professor Sheryl, thank you so much for joining us tonight. How are you feeling? I hope you are having a good day and are ready to give us some tips, some details on what we need to look out for, perhaps, and what we need to do if there is a male problem.
Thank you very much, Caroline. Thank you very much for inviting me to talk tonight. So I hope that I can give you some information about male infertility. So male infertility, it is a condition. I'm looking for my slides.
Sure, of course, I will show it in a second. I just want to remind everyone that, remember, we will start with Professor Sheryl's presentation on our topic, of course, and afterwards there will be time for your questions. You can put those in the chat section. It's all anonymous, so go ahead, ask anything you wish, and I'm sure Professor Sheryl will be happy to help you out with those. And yeah, I think we can go ahead with our presentation already, and it's right here, of course. Thank you so much.
Thanks. So male infertility is a condition that, beg your pardon, I think you've hit the wrong one here. Male infertility is a condition that affects approximately 1 in 12 men in the general population. And of all couples experiencing infertility, male infertility is the sole cause in approximately 20% of cases, while in another 25% or so of cases, there is both a male and a female factor. Hence, male infertility contributes to almost 50% of all cases of infertility, yet it is rarely given 50% of the time to investigate, diagnose, and manage the condition compared with its female counterpart. Now, as with female infertility, male infertility is a condition. And as with all conditions, we need to understand the underlying causes before any diagnosis can be made or any discussion or decisions can be made determining the treatment and management of this condition. Now, male infertility is clearly not understood. There is much in the media to suggest that male infertility is all about lifestyle and diet. Some in the medical community suggest that there is no point in investigating male infertility as there's really nothing you can do about it, while others claim that all you can do for male infertility is to provide a healthy diet and supplements. Indeed, most men with infertility are immediately referred for ICSI treatment without any further investigation. However, most people are actually unaware that male infertility is usually due to a medical condition, and that in many cases, the condition can be diagnosed, and in some cases, it can be successfully treated. So today, what I would like to do is to clarify this condition of male infertility by discussing how we identify male infertility and how this can help us to manage the condition. And in this way, I will attempt to bust some of the myths that currently surround male infertility. So contrary to the belief that male infertility is only about lifestyle, there are many clinical factors that can cause this. Now, the leading known cause of male infertility is a varicocele. And I know that you have had some excellent webinars on varicocele in this series, so I'm not going to explain about it too much, but it is the leading known cause of male infertility, both for primary and secondary infertility. And this is followed by hormone imbalance, or infections of the male accessory glands or the genitourinary tract. And other conditions that might be associated with infertility, apart from those presented here, include obesity, high cholesterol and dysfunctional lipids, high blood pressure, diabetes, as well as psychological stress and anxiety. Now, usually, the first test that we do to assess male infertility is a semen analysis. Now, while a semen analysis gives us some very important information about sperm, it doesn't explain the cause of the condition. Rather, it tells us what some of the effects of the condition are. So in order to understand what's causing the problem of male infertility, men, just like women, must have a comprehensive assessment with a thorough set of investigations. And without this, men may not get a proper diagnosis of their problem, and certainly they won't be able to be treated appropriately. Now, according to the European Association of Urology guidelines, a comprehensive andrological workup is always recommended for every infertile couple, irrespective of the semen parameters. So what does that mean? What is an andrological investigation? First of all, it's very important that we take a complete clinical history of the man. We need to know his fertility history. Has he fathered any children in the past? Has he been trying to conceive with his current partner for a long period of time? We need to take a family history. Is there any history in the family of testicular cancers? Are there any issues that could possibly relate to fertility and infertility in his family? We need to take a general medical history. What is his current health like? Does he have high blood pressure, obesity, diabetes, etc.? We need to see what other tests he's had done. Has he had any semen analysis? Has he had any other investigations? We also need to take a full history of his reproductive health. So, for example, very importantly, has he had any history of undescended testes when he was a child? Has he had any hernia repairs? Has he had any male accessory gland infections, for example? Does he have prostatitis? Very important to check his urological symptoms. Many men will start to develop urological symptoms and they'll think, well, it's just an age problem. You know, I'm getting up in the middle of the night to urinate. It's just an age problem. Or they may think that it happens so rarely that it's not worth thinking about. But these can be very important symptoms about something going wrong in your genitourinary tract that needs some attention. We need to check any history then of genitourinary tract infections because, of course, these are also associated with infertility. We need to know whether the man has had any surgery in the past or any injury to the lower abdomen or testes, because this can lead to permanent damage, and any treatment with changing your diet or nutrition isn't going to help if you've had any of these particular issues. Exposure to toxins. We want to know what you're doing in your work. Do you work with chemical toxins? Do you have hobbies that involve using pesticides, etc.? We also need to look at lifestyle and diet because it is important, and we need to know whether that might be also a contributing factor. So once we've taken a clinical history, it's also important to consider a physical exam. Now, the physical exam will ensure the size, the texture, any abnormalities in the testes. The doctor might be able to determine whether or not you're lacking a vas deferens, which is the tube that leads from the testis out into the urethra. They need to check whether or not you might have a varicocele, and a doctor who has experience in examining you for that will be able to tell if there is a clinical varicocele there usually. Other physical alterations, such as abnormalities in the curvature of the penis for delivery of sperm, can also be affecting one's fertility. An ultrasound scan, just like for women, is also very important just to check that everything is okay. There are certain things that you can't determine just from a physical exam. It can help to measure any abnormalities in the testicular structure, to detect possible tumors, to confirm varicocele, and to look for signs of obstruction. Now, of course, it's very important to do a semen analysis as well, and that must be included. And from a semen analysis, we can look at the volume of the sample, which is actually determined by the function of the male accessory glands. So any loss in volume will indicate a problem with the male accessory glands. Sperm numbers will tell us whether the testes are functioning normally, whether they're making normal numbers of sperm. The motility is very important because it can tell us whether or not there's something toxic in the environment, so that the sperm are starting to slow up, they might start to die, and this is also very important. Morphology is also something that people worry about. It is an important parameter, but as you can see, the reference value for this is 4% normal forms. That means that a normally fertile man may have as many as 96% of his sperm that have an abnormal shape. And a lot of people get very upset about it, but it's quite usual to have people with only 4 or 5% normal forms. It doesn't seem to affect your fertility. The question is, what is morphology and what does it mean? And a lot of people have a lot of questions about that. So if we determine, first of all, what does a normal sperm look like? So on the right here, we've got a photograph of a stained sperm. So this is a human sperm that is stained, and it looks, for all intents and purposes, quite normal looking. It has a nice oval head, and if you can make out, about 50% of the top of the head stains slightly paler blue. And this is because this is a particular structure on the top of the head called an acrosome, and it's very important that it has an acrosome because the acrosome contains the little proteins that eat away through the egg coat and allow the sperm to get in. So if you don't have an acrosome, you're going to have a problem for your sperm getting in. On the left is a little diagram of the sperm, and as you can see, just below the head is a little area where it contains things called mitochondria, which generate the energy for the sperm to move. And then the tail itself, which is responsible for driving the sperm forward. Now, when we define abnormal sperm, the sperm here on the top left are all abnormal. And I know people get a lot of anxiety when they're diagnosed with 0% or 1% normal forms. But if they all look like the ones on the left, they're not too bad, are they? But if you look at the ones on the top right, they are grossly abnormal. And you'll notice that they are lacking this acrosome on the top of their head. A lot of them have coiled tails, so they're not able to move. And there are lots with double tails as well, which are very abnormal. If you look at the sperm on the bottom panels, on the left, you have sperm that look very round. They are technically termed globozoospermia, and these sperm never have an acrosome, and they are unable to get into an egg ever. They cannot get into an egg on their own. And the ones on the right have no proper tail, and they cannot move, and they will never get into the egg of their own accord either. These conditions mean that a man would be totally infertile without some form of assisted conception. And any change in diet or lifestyle is not going to affect this, because this is due to an underlying genetic condition, and this is a serious problem. But it's quite rare that a laboratory will actually report on the type of morphological defect. And I think this is really very important if you really want to understand what 100% abnormal forms actually means for you. So the question really is sperm morphology a good predictor of fertility? A lot of people go absolutely crazy when they have 0% or 1% normal forms. And the question is, what does it really mean? It's not always a very good predictor of infertility. While some studies do show that poor morphology is related to a lower pregnancy rate with IVF and ICSI, other studies have shown that abnormal morphology is not necessarily associated with a significant decrease in pregnancy rate with IVF. And I think this is about, you need to understand what the type of defect is. So there's bad sperm and there's super bad sperm. But we also know that it is possible to conceive naturally with 100% abnormally shaped sperm. And I've listed some of the references below. Now, we're all very caught up with sperm count, sperm motility, sperm morphology, and we tend to ignore the rest of the parameters on a comprehensive semen analysis. But don't forget, a semen analysis is about the semen. And the semen contains sperm, but most of it is fluid. And the fluid comes from the male accessory glands. So a lot of the other detail on the report is going to give you information about how your male accessory glands are functioning, your prostate, your seminal vesicles, how healthy are they? Because if they're unhealthy, this is going to affect your fertility. So we look at things like the appearance of the sample, which can indicate a pathology, even if you have blood in your semen, obviously something terrible like a cancer perhaps. But we can also look at things like pH, volume, viscosity, and white cells that might indicate male accessory gland infection. Volume, pH, and count might indicate an obstruction. If there's antibodies there, it can indicate immunological infertility. And if we have a very low count, a very low volume and the count is affected, this might even indicate a retrograde ejaculation where people don't ejaculate out of the penis, they ejaculate up and back into the bladder. So that means either you end up with no ejaculate or you have a very small ejaculate because most of it has gone back into the bladder. On the other hand, we might want to ask the question, if we're diagnosed with a normal semen analysis, does that mean I'm fertile? And quite often people go to their doctor and the doctor says, oh, you're fine, there's nothing wrong with you, off you go. But unfortunately, a normal semen analysis does not necessarily mean that you are fertile, because 25 to 30% of cases of male infertility remains unexplained. That means you've got normal sperm, nothing's happening. So what do we know about semen analysis? How predictive is it of our fertility? Now, we know that there have been a lot of studies looking at this, and a lot of the studies show that the prediction of male infertility by the World Health Organization guidelines is actually not a very good predictor of infertility. So, what does the semen analysis actually tell us, and what is the limitations of it? So we know that the semen analysis tells us about fertility potential, doesn't tell us 100% what it is, but it gives us an indication that if your semen parameters are normal, you are more likely to be fertile, but we can't guarantee it. And likewise, if they're not normal, you're more likely to be infertile, but we can't guarantee it. So that's what it's telling us. It can also tell us about testicular function, whether we're making enough sperm, whether the reproductive tract is open and there's no obstructions, an indication of male accessory gland infection, as I showed you before, and possible indication of pathology. But what it doesn't tell us anything about whether the sperm, when they get to the egg, are able to bind to it, whether they're able to fertilize the egg when they get into it, whether they're able to generate the signals that are required to generate a healthy embryo, and whether or not the DNA, the genetic material inside the sperm, is actually healthy. Because if you've got unhealthy genetic material that you're putting into the egg, irrespective of how many sperm there are and how well they're swimming, the embryo is not going to be healthy. And you will not get implantation, or if you do, you increase the risk of miscarriage. So in other words, a semen analysis is a bit like going to the car showroom and you see the car and it looks beautiful. But what you haven't done is check the engine. And this is what you really need to be doing. So let's look at why we're sort of limited in what we're looking at. Sperm were discovered by Antoine van Leeuwenhoek in 1677. He put a little drop of his semen under his very lovely little microscope back in the late 17th century, and he discovered sperm. But it wasn't until nearly 200 years later, in 1930, that semen analysis was introduced as a test for male infertility. Go forward another 50 years and we have the first World Health Organization laboratory manual for assessing semen analysis. And we have been assessing semen analysis using World Health guidelines now with updated versions, with the last version coming out in 2021. And all of these analyses have all involved the microscope. Now, the microscope is very good. It can see a lot more than our eyes, but it cannot see the molecular level. We cannot see what's going on inside the sperm. So, over the last 40 years or so, we now are able to implement different methods of analysis of sperm that actually looks at the genetic material of the sperm, the DNA. And what we now understand is that DNA damage or DNA fragmentation is crucial for affecting fertility, and DNA fragmentation levels are much more highly correlated with infertility than any of the individual semen parameters that you see on a semen analysis. Furthermore, we now know that the underlying factor that is most likely responsible for DNA damage is an increase in oxidative stress in the reproductive tract. And by oxidative stress, I mean an overproduction of oxidants. Now, oxidative stress and sperm DNA damage have been shown in many, many papers to be significantly higher in men with infertility, and in particular in men with unexplained infertility. We also know that oxidative stress and sperm DNA damage can be present when the semen parameters are perfectly normal. It's also associated with almost all of the known causes of infertility, such as varicocele, infections, hormone imbalance, poor lifestyle, poor diet, heat damage. All of these things are associated with oxidative stress and sperm DNA damage. And in fact, we now know that the molecular mechanism for how all these things work is through the generation of oxidative stress and sperm DNA damage. And finally, we also know that these molecular events are associated with a significant delay to conception, implantation failure, reduced pregnancy outcome with assisted conception, and an increased risk of recurrent miscarriage. Now, fortunately, there are tests available now, both for oxidative stress and to measure sperm DNA fragmentation. There are lots of different tests out there that you can use to identify oxidative damage and DNA damage. But the problem is that a lot of fertility clinics are reluctant to offer these tests. And we need to ask, why is that? First of all, some of the reasons could be that you could argue that none of the tests are validated. This is not quite true. We know that in the UK, UCAS has accredited an oxidative stress test and also sperm DNA fragmentation testing. Furthermore, in the United States, the CLIA, which is the UCAS equivalent, has also validated these tests. You could also argue that each of these tests gives different results. That's true, they do. DNA damage is not simple. The DNA is a double-stranded molecule. It can be damaged at any point. You can damage the inside bits, the outside bits, the single strands, the double strands, and all of these tests measure different things. That they give you different results doesn't invalidate the test. It shows you that there is some damage somewhere. You could also argue that there's insufficient evidence to show they affect fertility. Well, we've been talking about DNA damage for the last 50 years, almost. There's a plethora of papers out there in both the human and animal world in studying this. And both the European Association of Urology and the European Society for Human Reproduction and Embryology have now acknowledged that there is sufficient evidence to use these tests, especially for patients with recurrent miscarriage. And I would also say that there is some evidence to show that it's important for unexplained infertility as well. Finally, we get the suggestion that even if you did do these tests, there's no point because there's nothing you can do to change the management of the treatment for the patient. So why bother to do the test? And I would like to spend the rest of my talk talking to you about how this is really not the case. So first of all, we can ask the question, what can be done to treat oxidative stress and DNA fragmentation? Well, mostly it can be treated, but it does depend on the cause of the problem. So firstly, we know that oxidative stress, as I said, is an overproduction of oxidants. Now, naturally, you have in your system a lot of antioxidants if you eat a good, healthy diet. So we know that antioxidants are very prevalent in fresh fruit and vegetables. And if you eat a lot of those, hopefully, you'll have a lot of antioxidants in your system to mop up the oxidants. But if you don't, you can take supplements, which are antioxidants. So the supplements, the scavenging molecules, all the vitamins and the minerals and all these things that you always took and never knew how they were working, they actually work by reducing oxidative stress. But the problem is they don't always work. They only work if you have oxidative stress. But if the oxidative stress is caused by some condition that's churning out huge amounts of oxidants, maybe the antioxidants that you take with your supplements is not sufficient. So it really does behove us all to investigate the causes of the oxidative stress and the DNA damage. So there may be many causes of oxidative stress and DNA damage. And once we understand that, we can make suggestions on how we can treat it. So firstly, let's look at the patient. There's a lot of evidence out there to show that as men get older, especially when they get into their 40s, DNA fragmentation levels start to increase. We also know that if men don't ejaculate regularly, the semen samples that they produce have a higher level of DNA damage. We know that any heat exposure, including high fever, like COVID, for example, will cause DNA damage temporarily in the sperm, and that is also a problem. From a clinical point of view, any testicular trauma, varicoceles, infections, all associated with oxidative stress and DNA damage. From a lifestyle point of view, we're looking at obesity, poor diet, smoking, recreational drugs, or prescribed medication all cause this. And of course, any environmental toxins such as ionizing radiation, any endocrine disruptors, or pollution in the environment will cause this. So if we know this, how can we treat it? So for the patient, we can't do anything about his age, but we can encourage him to ejaculate frequently. You mustn't store up sperm and only have sex at the time of ovulation because your sperm will be damaged. You need to ejaculate regularly every 3 to 4 days. You need to keep your testes cool. From a clinical point of view, if there are infections, we need to treat those infections. If there's a varicocele, we need to repair it. In terms of lifestyle, we need to reduce toxin exposure and improve our diets. And if all else fails, there are now specialist advanced techniques which are offered in some IVF units to physically select sperm that have a lower DNA fragmentation. And this would be something like Pixie or Zymot, which some of you might have heard about. Now, if all else fails, we do know that there is evidence now to show that because the testicular environment is more protected than the sperm that comes through the epididymis or out into the ejaculate, if you have very high DNA fragmentation levels in the semen, it might be worthwhile having a chat with your urologist to talk about retrieving sperm from the testes, as that has been shown to have lower DNA damage. Now, are there any other tests for unexplained infertility? Well, we do know that there's now significant evidence that the microbiome may play a role, and we can do some genitourinary tract infection screens for this. What is the microbiome? It describes the community of microorganisms that live within us. And it consists of all the little organisms like bacteria and fungi and viruses. And they all live together in balance. But if things get out of kilter and you get an overgrowth of certain organisms, we become unhealthy. And that's true if that happens in our reproductive tract. Common conditions in women is bacterial vaginosis. In the men, they don't get symptoms, but the women are treated. The men don't get treated. The men act as a reservoir. The women feel great for a few months. Then they go and have intercourse with their partners again, and then it comes back again because the men aren't treated. So basically what we need to do is we need to check the men. We need to treat with antibiotics if there are infections there, and we need to supply probiotics to bring back the good bacteria that might be absent. We also need to think about specific tests for people with very low sperm counts or no sperm. And they do need to have tests for underlying systemic illness because the poor quality sperm may be a reflection of an underlying illness that they have. We need to check their hormone profile, and we also need to do some genetic screening as well because it may be a genetic cause. So once you've had all these investigations, how can your fertility be improved? So we can do this once we know what the cause is. We can try and improve things. And I've tried to show you how we can do that, certainly with oxidative stress and DNA damage. But for some of the other causes of infertility, we might want to look at the role of lifestyle because it's very important that we address this in addition to addressing all of the conditions that we've identified. Because although lifestyle is rarely the main factor, unless you're a drug addict or you exercise to excess like this, or you drink and smoke 40 cigarettes a day and do drugs, most people are living sort of average lifestyles. So the lifestyle is important, but it's very rarely going to be the most important contributing factor unless we do things to excess. But I think generally there are treatment options for men, as you can see here. And I think it's very important that we investigate and deal with these things appropriately so that people can then improve their chances of a natural pregnancy or even improve their chances with IVF if they have to have it. So I hope in this talk that I've been able to bust some of these myths that are floating around, and that basically I just want to put over the points that male infertility is a condition caused by many different clinical factors which may be exacerbated by diet and lifestyle, that it must be properly investigated so that men can be treated appropriately, and that IVF treatment should only be offered as a last resort if management of the condition fails to result in a natural pregnancy. Thank you very much.
And thank you so much indeed for your thorough presentation. I think you've covered pretty much the most important parts of this. So thank you so much, Professor Sheryl, for your time and presenting this particular topic tonight. And of course, now everyone's favorite part, let's be honest, Q&A session is about to start. And as you can see, there are some questions right here, but of course, we are here for you. If you have any other questions, go ahead, type those in. And let's go ahead with the very first question that we got, which is, of course, one of the most popular ones, I would say. Do you think that diet supplements can influence the quality of semen?
So I think that hopefully I answered the question there. I think that the diet is very important. Diet is really important for your infertility, but it's rarely the major factor unless, as I say, you're obese, or if you are severely underweight, or you're on restricted diets, that you're not getting all the vitamins and minerals and nutrients that you need. Supplements is a difficult one, because I am a fan of supplements, but I'm a fan of supplements if they're taken properly. So it's like I'm a fan of antibiotics because I know that they treat bacterial infection. But if you don't have a bacterial infection and you're not well, taking antibiotics isn't going to help you. And it's the same thing with supplements. You need to do an oxidative stress test, because supplements are antioxidants. If you don't have oxidative stress and you take supplements, you can put yourself into reductive stress. And that actually has a similar effect to oxidative stress. So they can be quite dangerous if you take them and you don't need them. So that's why I'm saying it really is very important that you do an oxidative stress test before you take the supplements. There are situations, if we know that people are really struggling with motility, for example, in their sperm, or the sperm quality is really poor, it's possible that taking supplements, but not too many, people do take supplements, they take one, and then their friend's taking something else, and somebody on the internet says, and they take 100 million supplements. Don't overdose it either. You'll put yourself into serious damage. Just one supplement, one recommended supplement.
Thank you so much for repeating that, because I think it's that happens very often, that you think that you need to take everything and it's not actually very wise to do. Thank you so much. Okay, this is a question from Derek, the second one. Okay, so just give me a second. It's a statement, but maybe you can help us here. So can a physical exam determine underlying varicocele?
If it's done properly, and it's a clinical varicocele. There's different grades of varicocele. So subclinical might not be determined simply by a physical exam. But if you've got a doctor who knows what they're doing, they can pretty much identify a varicocele. But even then, my consultant urologists who specialize in male infertility, who do these exams all the time, will still get it confirmed with an ultrasound scan.
Okay, thank you for the clarification. Debbie has a different question for you. So in what instances would microtese help select better sperm for IVF-ICSI?
So microtese is the surgical retrieval of choice for people with azoospermia, with no sperm in the ejaculate. Microtese, there's been all sorts of reviews coming out, and that is definitely the best way to obtain sperm from a patient with azoospermia and obstructive azoospermia. The only other time that you might want to consider microtese, as I said, is if you've got very high DNA fragmentation levels in an ejaculate sperm, where you've done all the investigations and you can't find any particular cause. You've taken all the antioxidants and it hasn't reduced the DNA damage. So as a last resort, I would recommend microtese testicular sperm, to use that instead of ejaculated sperm with ICSI treatment.
All right. Thank you, Debbie, for your question, and Professor Sheryl for your help with that as well. Okay, what about this question again from Derek? I needed to check that. Do you believe in reactive oxygen species during centrifuge processing?
So it's not a belief, it's a fact. So oxidative stress probably does increase during centrifugation. The question is, does it increase to a level that it's actually going to damage the sperm? When we're preparing sperm for IVF or IUI, there's different ways of preparing them. One is centrifugation and one is swim up. With a swim up, you've got the problem that you've got potential debris in the semen that the sperm are exposed to for too long while they're swimming up. So, and in the centrifuge, you might trigger oxidative stress production, free radical production as well. So it's 6 to 1 and half dozen the other. What I recommend is that you use as minimal centrifugation as you can, the minimal steps, and that you reduce the speed to the absolute minimum. And that you use the sperm as soon as you've prepped it. Because once you leave it in the absence of semen, without the antioxidants in the semen, that also causes problems. So you need to prep the sperm and use it for IVF and IUI immediately. This must be an embryologist that asked this question.
That's true, I think, because Derek has been with us before, but as you can see, he says thanks, and I just wanted your opinion. And thank you so much indeed for joining us tonight as well, and for that question. Okay, let's have a look. More questions are right here. I will show the slides in a second. Can you please provide the slide with all the treatment options for the various causes of male infertility, ligation for varicocele? Do you remember which slide it was?
I think it's the second from last. Third from last. Yes, I can find it. Sorry.
Yeah, I think it's right here.
Whoops.
Yeah.
There
this is the one. And of course, remember, it is recorded, okay? So that means you will be able to simply watch this tomorrow and have a look at this once again, all right? I hope that helps. And now let's go to the questions that we have. And the next one is here. Do you know which clinic in London provide oxidative stress test?
I think a lot of clinics are providing them now. The one that a lot of clinics are providing is something called the Meoxis test, which is the redox potential test. And a lot of fertility clinics are offering those now. The clinic that I'm consultant lead for is not a fertility clinic, it's a diagnostic clinic. Unfortunately, it's a private clinic, so you have to pay for the test. But at that clinic, which is the doctor's laboratory, they offer both the Meoxis test and also the chemiluminescence test for reactive oxygen species. So they run them both. And both of those tests have been validated and they're both UCAS accredited.
Okay, thank you for that question as well. And there's one more thing from Derek here. Let me just show you, okay? So general semen analysis pre-IVF or IUI needs to get more advanced, especially when you can do a sperm diagnostic test regarding the condensation test. It's more important than fragmentation. I apologize for explaining more. Anything you can add to that?
Okay, so decondensation. You're talking about DNA decondensation, the halo sperm test. Is that
yeah, Derek, if you can just confirm that for us, just to make sure. Someone is typing, so we just need to give it a second.
Yeah. So,
yeah. Right here.
Sperm decondensation time. Decondensation test. Decondensation. Do you mean nuclear decondensation? I'm a little bit unclear what you mean by that. Sorry.
It's okay. I mean, I think that Derek is typing, so we can have a minute. But of course, remember that if you would like to get some more like details on that more embryological level as well, I guess, you can always get in touch with Professor Sheryl. I am always able to forward this, and I'm sure you will be able to get back to Derek as well. Okay.
Of course.
So thank you so much. And in the meantime, we did receive one more question here. Okay, and Derek has sent me a link here. Okay, I will be able to forward this as well. Not a problem at all. Okay, and let's have a look at the question from Kinza. In case of azoospermia, role on FIBMS, can you explain?
Yes, so I mean, again, it's very difficult to know about azoospermia and the role of inhibin, because there have been studies looking at levels of inhibin, levels of FSH, all these sort of hormone markers for spermatogenesis. And actually, when you come to do surgical sperm retrieval, they really aren't very good indicators at the end of the day as to whether or not we would actually find sperm. So I think it's very important. We need to be measuring these factors. Again, they're indicators, but at the end of the day, they can never really tell us for sure about whether or not there is, Sertoli cell only, or whether there is some spermatogenic arrest, or what the situation is.
Understood perfectly. Again, thank you so much for this. And there's a thank you from another patient. And that might have been our final question. So thanks everyone for all of your questions and for your time. And of course, as I mentioned, if you wish to get some more details, I know that it's possible for you to get in touch with Professor Sheryl, and I'm sure she'll be happy to help with some of your questions as well. And well, thank you so much, Professor, for being with us tonight. As I mentioned, this is very important talk that we should discuss more and more. So thanks a lot for your time, and I hope that you found this also interesting for you. And also, if there's anything else you would like to add before we finish.
Well, I just want to thank you very much for giving me a platform to raise awareness for male infertility, because I think this is, as you said, it's very sort of under-investigated and just kind of marginalized. So thank you so much. It's been my pleasure. And thank everyone for contributing with your questions. It's been an interesting discussion. So thank you so much.
Definitely interesting. And as you can see, there are some comments that I would like you to see. Thank you so much. This has been so informative, and of course, informative for sure. That's what you see from all of our patients. So I'm glad that we are able to talk about it and spread the word even more. So hopefully we'll have another chance to cooperate and also have another talk like this. And as you can see, more comments, so really nice to see that, and we are happy that we were able to answer also some of your questions. So thanks a lot, everyone. Have a lovely evening, and of course, Professor Sheryl, I hope to have some more events coming up with you. So we are in touch, everyone. Take care, and see you soon as well. Thank you. Bye.